Henoch-Schönlein purpura is a small vessel vasculitis, and it's often seen in children and teenagers, but it can also be seen in adults also. You tend to present with palpable purpura which affect the dependent areas, so the rash is often seen on the buttocks and it's often seen on the legs as well. And it might start off just as these hive-like lesions, but then it develops into these palpable kind of reddy purple purpura. So if you run your handle on there, it will feel raised. Males tend to be affected more than females at about a 2-to-1 ratio, and there are a number of triggers that can cause Henoch-Schönlein purpura. So one is upper respiratory tract infections, and many patients tend to be positive for streptococcus on either throat swabs or with serology. And there are also a number of drugs that can cause it. Culprit drugs include ACE inhibitors and NSAIDs. With regards to the pathogenesis, you get blood vessel inflammation, and this is due to IgA deposition within the blood vessel walls. As well as getting the rash, the patient can present with an arthritis, and this tends to occur in about 3/4 of patients. And arthritis tends to affect the ankles and knees, but it can affect other areas as well. You can also get abdominal pain in about 50% to 3/4 of patients, and this can be associated with diarrhea and minor GI bleeds. Rarely and more frequently in the younger populations, you can get intussusception as well. Kidney involvement is common enough, and you can often get mild kidney impairment, and this is seen in about 50% of cases. But you can also get severe kidney impairment, and this can be seen in about 5% of cases. And it can actually occur up to about 1 month after the initial symptoms. So it's important that the patient is followed up with repeat UNEs and urine looking for protein and blood for a period of time after they present. Of note, IgA is elevated in 50% of these cases, and they may also get a leukocytosis or eosinophilia. With regards to treatment, you only really give them prednisolone or immunosuppression for severe GI or renal involvement. They tend to recover in about 4 weeks, but as I mentioned before, you really need to watch out for renal impairment. So now I'll move on to alopecia, which basically means hair loss. And one common type of alopecia is alopecia areata. So this is an autoimmune condition, and it can present in a variety of ways. Probably the commonest one is where you get a patchy alopecia. So that's kind of loss of hair that leaves single or multiple discrete, and they're often round areas of baldness on the scalp. But it can affect other areas such as the beard area or any other hair-bearing part of the body. Alopecia totalis is where all or nearly all of the scalp hair is gone, and alopecia universalis is where all or nearly all of the hair from the scalp and the body is gone. So there's particular signs you can look for if you're looking for alopecia areata. So you can often see this thing called exclamation mark sign. So if you look at the edge of the lesion, you might see these hairs that are very short when they're close to the scalp, and then as they get further away, they're thicker. So that's one sign that it might be alopecia. So this is kind of patchy alopecia. I suppose this would probably go under alopecia totalis or be close enough to it anyway. And it is an autoimmune condition, as I mentioned before. So there are multiple associations, such as vitiligo, thyroid disease, pernicious anemia, rheumatoid arthritis, and diabetes. 1/3 of patients that get alopecia tend to have a positive family history, and thankfully, many patients experience hair regrowth in about 9 to 12 months. And initially, the hair can regrow and it's colored grey, but with time, that will then go back to normal. Important thing, and thankfully, no scarring occurs with this form of hair loss. But there are some subgroups that don't really ever get good hair regrowth in those areas, unfortunately. So treatment's really mixed. You can consider topical steroids, can consider using minoxidil, and you can consider using Puva. But to tell you the truth, there's no great treatments out there really. There's other causes of hair loss that I just wanted to mention. So a thing called trichotillomania, I think it comes up in questions sometimes, and this is self-inflicted pulling out of one's hair, and often arises in people with obsessive compulsive disorder, or people who are just highly anxious, and it often develops as a coping mechanism for stress or anxiety. And so, if you know, I suppose in the MCQs, there'll probably be a clue that they might have something like this, like anxiety. And then on exam, you'll often see these irregularly shaped patches of alopecia, and the lengths of hair are different within those patches. Telogen effluvium is another cause of hair loss, and this is a generalized type of hair loss that can often occur after an insult, or more colloquially, after a shock to the system. So it can occur after things such as infection, general anesthetic, even things like grief, and it usually occurs about 2 months after the initial insult. So now I just want to mention that there are certain types of hair loss that do end up with scarring, and I suppose the major types that will probably come up in exams will be discoid lupus and lichen planus. We've been on lichen planus already in a previous video. Other more less frequent causes are scleroderma, radiodermatitis, and also severe fungal infections can sometimes cause a scarring in alopecia. And in these cases, the hair follicle is destroyed in all of them, and you are not able to ever get regrowth in these areas. Now I move on to blistering conditions, and there's quite a few of these, and I imagine they can come up quite readily on the exam. So the first one I'll talk about is dermatitis herpetiformis, and this is an extremely itchy condition, and it's associated with a gluten-sensitive enteropathy. But this enteropathy may be completely asymptomatic. It is most commonly seen in the third or fourth decade, and they tend to get this extensor rash, and it tends to be a bilateral rash, and it tends to be on the extensor surfaces. So the classic areas that are affected are the elbows, um, the buttocks, the shoulder, and also the scalp. And what you often get is you get these they're not almost most of the time they're not even big enough to be blisters. You often get these small vesicles that are extremely itchy. So when they often come into the clinic, they've already been scratched, and you can often just see these erosions. The mucous membranes can be affected, and skin biopsy shows IgA deposits, funnily enough, in the unaffected skin. So oftentimes when you're taking a biopsy, you actually take a biopsy beside the affected areas. And interestingly, dapsone is an extremely effective treatment for the itch. It works almost immediately, and then if you get the patient on a gluten-free diet, they should be cleared of the disease after a period of time. So this, I suppose, is the buttocks from the looks of it, and then this is another image of the elbows. And again, you can't really see any intact vesicles; they've probably been scratched, and you can just see these erosions. Um, now, as I said, less than 10, they often actually don't have a gluten sensitive enteropathy, and actually only about 10% of patients have symptoms, but greater than 90% will have abnormalities on endoscopy, and two-thirds will show villus atrophy on biopsy. So now moving on to the next one. So there's bullous pemphigoid and there's pemphigus vulgaris, and there's differences between these which are really easy targets for MCQs. So bullous pemphigoid is a disease of the elderly, and in bullous pemphigoid you present with these tense blisters with usually a surrounding urticarial rash. And it's an autoimmune disease, and it's characterized by the presence of IgG autoantibodies to components of the basement membrane. So the basement membrane is the area that separates the epidermis from the dermis. So the split is quite deep compared to other blistering disorders, and as such you get these tense blisters that don't spontaneously rupture. Oral involvement is rare enough, only in about 10%. And usually with cases like this, we treat them with high dose oral steroids and then taper them down to a dose that keeps the blisters at bay. Other options include using dapsone also as a steroid sparing agent. So as I said, here is kind of an urticarial rash, which this kind of urticarial itchy rash can often precede the blisters by weeks, and then after a while you develop these very striking tense blisters. And here's another example. So pemphigus vulgaris, in comparison to the tense blisters of pemphigoid, in pemphigus vulgaris you get flaccid blisters, and they're often actually, once the patient arrives in to see a doctor, they often just present as erosions because the blisters have already burst. And large areas of the body can be affected, and mortality without treatment is actually high. So this has actually got much worse prognosis than bullous pemphigoid. And here's an example where we can see quite a bit of the body surface affected. You actually can't see any intact blisters there really, and all you can see are these erosions. Mucosal involvement with ulceration is very common, and it's usually actually the presenting sign in up to 50% of cases. And the blisters can be extremely sore, and the blisters in the mouth can be extremely sore. And as I mentioned, they rapidly denude, so you often only just see weeping erosions. They show a thing called Nikolsky's sign. So if you have a blister that's kind of intact, you can extend it with gentle pressure on the fingers, rubbing the finger against the skin. So like bullous pemphigoid, it's due to deposition of IgG, but in this case it's higher up. So the deposition is in the epidermis, and it's not near near the basal layer. So a skin biopsy will show that the split is above the basal layer, and in this case we treat with high dose steroids, and we might add in azathioprine, which is an immunosuppressant, and we can use that as long-term maintenance. Um, I've written it here, and apparently you may have an increased risk of skin malignancy. So as I showed that image already with multiple erosions, here is oral involvement that you can get with pemphigus vulgaris. I've only ever seen it once, and it was in a lady, and she had very extreme pain, and she couldn't really swallow or anything, and she was really in a bad way with it. So here's just an image. Here's a very simple schematic of the epidermis. So this is the basement membrane, this is the basal layer, and this is going up to the surface of the epidermis. So pemphigus is superficial and pemphigoid is deep. So now moving on to porphyria cutanea tarda, and this is another blistering disorder, and the clinical effects are due to increased porphyrins in the bloodstream. And as we know, porphyrins are part of the metabolic pathway to produce heme. And porphyria cutanea tarda can be inherited, but it's usually acquired due to liver damage. And what happens is you get decreased activity of the liver enzyme uroporphyrogen decarboxylase. And this deficiency blocks the pathway for heme synthesis, and it leads to increased porphyrins in bloodstream. And predisposing things that can cause this liver damage and decrease activity of the enzyme include alcohol, smoking, estrogens, hepatitis C, and hemochromatosis. And when you get increased porphyrins, they enter into the skin, and then they're activated by UV light that shines onto the skin. And this can cause damage locally, and this gives the clinical effects. So the classic example that you might get asked in the MCQ is a person that's been away on the holiday and drinking a lot. So he's had liver damage due to the alcohol, which releases porphyrins into the blood, which then get into the skin, and then the UV light due to the sun activates these porphyrins and causes the damage. So they often present with these blisters on the dorsums of the hands, tends to be the main areas where it affects, and these because this where the split occurs is quite deep, you actually tend to get this scarring, and you get these things called melia, which I'm not really sure if I can see any there, but they're often these, well, I suppose that is scarring, but you often also get these white little pearly areas that called melia, which you can see under the skin. And for some reason as well, patients often get hypertrichosis. So this might be seen, noticed more in females, in which they get excess hair on kind of on the cheeks. So diagnosis of porphyria cutanea tarda can be made by increased levels of plasma and urinary porphyrins. And treatment tends to be making sure that the patient uses good sun protection, that they cut down on alcohol, repeated venesection helps as well, and then the antimalarial chloroquine can be quite effective as well. And as I said, diagnosis depends on increased levels of plasma and urinary uroporphyrins. And in clinic, I don't know how often this is actually done, but if you examine the urine with a Woods lamp, the urine will show a pink fluorescence. And this basically, it means the Woods lamp is showing up the increased porphyrins in the urine. Now, there is a differential diagnosis for this. So, if you have similar clinical features, but the porphyrin levels are completely normal, it could be a thing called pseudoporphyria. And this presents in the exact same way, but it's often a reaction to medications. And NSAIDs tend to be the big ones that cause this. Necrobiosis lipoidica is a rash that is often associated with diabetes mellitus, however, it can also occur in non diabetics. That's due to small vessel damage, which leads to partial necrosis of dermal collagen. Is more commonly seen in young and middle-aged females, and when you look at the rash, the skin appears thinned. So it often occurs over the shins, and it often initially presents as an erythematous plaque that gradually develops a waxy, kind of yellow-brown discoloration, and oftentimes you can see visible telangiectasia scattered throughout, although that's not too clear here. And even on occasion, it can sometimes ulcerate due to the thinning of the skin. And treatment is simply with support bandaging, and you may consider low-dose aspirin, which can help with the healing. Dermatomyositis is a connective tissue disease, and importantly, when it develops in patients over the age of 40, one-third of these will have carcinoma. It is more common in females, and it can cause a number of different types of rashes. A rash can often affect the extensor bony prominences of the shoulder, the limbs, and the back of the hands. And I'll just show a few of the different types of rash that you can get here. So you can get a thing called a heliotrope rash, which is kind of a purple rash that is seen on the eyelids or around the eyelids. You also get a bit of swelling or edema in this area often as well. You can also just get a generalized photosensitive rash, and again it's kind of purpley in color often. So here we can see a rash that is kind of affecting the areas that would have been exposed from the t-shirt. Um, and then you can get another phenomenon that is seen in dermatomyositis is Gutschen's papules, and these are simply papules or plaques that are located on the knuckles and joints of the small of the hands. If you get a rash in lupus around this area, the rash is often seen in between the knuckles and the joints of the hands. Um, the you can, if you look at the nails, you can often see gross dilatation of the posterior nail folds, and with dermatomyositis, you often get weakness of the major proximal muscle groups. So, of course, you ask them if they've had any difficulty, sitting up from a chair, climbing the stairs, or combing their hair. Rarely, you can get involuntary muscles affected also. So you may ask them about any swallowing or breathing difficulties. You could consider doing, testing for seeing if their swallowing is fully intact. And you might also consider PFTs if they report any difficulties with breathing. Rarely you can get calcification, which could be painful, but this is often in childhood and it's often in the deep muscle planes. So, in regards to diagnosis, you'll do a creatinine kinase, which will often be elevated. A muscle biopsy will confirm the diagnosis. With regards to antibodies, most patients will be ANA positive, and it can also be associated with positivity of anti-Jo1 and other antibodies, which I won't go into here. But the presence of anti-Jo1 is often associated with pulmonary involvement. So basically, you can get pulmonary fibrosis. There are different subtypes of lupus that we can come across. We can come across acute, subacute, and discoid lupus among other subtypes. Most patients with discoid lupus just have skin involvement, but 5 to 25% may go on to develop SLE. It usually affects the sun-exposed areas, so the face, neck, scalp, and hands are often affected, and again, females are affected more than males in about a 2-to-1 ratio. Patients often present with well demarcated plaques which may have overlying scale. The plaques can then become atrophic and heal with scarring. They are often left with significant pigment change. The scarring often looks darker on Caucasian skin and paler on black skin, and you can also get telangiectasia within these plaques. Scalp lesions are common, and they lead to destruction of the hair bulbs, which can lead to a scarring alopecia. So if you look closely, you won't be able to see the follicular ostia in these areas. The diagnosis is often made by skin biopsy, and only a small proportion actually have circulating ANA, and this may indicate a risk of progression to systemic lupus. Treatment is with topical sunblock, and it's very important to stress the importance of sun protection and also topical steroid creams. The first line systemic agent tends to be the antimalarial hydroxychloroquine, which is also known as Plaquenil. I'll move on to subacute lupus now, and again, it's often precipitated by sun exposure. And the lesions you get can often look like a psoriatic type papulosquamous rash, or else you can often get this annular or circular type plaques that are clear centrally. And importantly, there's no scarring seen with this condition. Compared to discoid lupus, which is a low association with SLE, and acute lupus, which is a higher association, I'd say that subacute lupus has a medium association with SLE. And the antibody that you tend to see in this subtype is the anti-Ro antibody. And you can also get a drug-induced form of subacute lupus, which is clinically distinct to the drug-induced systemic lupus we see. And it's associated with anti-seizure medication, PPIs, and the anti-TNF biologics. In this image here, we can see some annular type plaques with central clearing. However, oftentimes this is actually much more prominent than this photo here. Uh, and now we'll move on to acute cutaneous lupus. And this variant has the highest association with systemic lupus. And the classic presentation we're all aware of is the malar eruption, or what's colloquially known as the butterfly rash. And here we can see kind of very markedly red lesion on both cheeks, and it also crosses the midline over the bridge of the nose. And you can get other variants of acute lupus, apart from this butterfly rash, such as just a generalized photosensitive rash. You can get blistering type of lupus. You can get cheilitis, or kind of cracking around the corners of the mouth, associated with mouth ulcers as well. And sometimes you can just get a papular rash on the arms, which can go on to form large plaques. Systemic sclerosis is another connective tissue disease we see in dermatology, and it's quite a tricky one as treatments aren't particularly great for the visceral involvement, and it can be quite disabling for patients as well. So skin features can include microstomia, which is small mouth, the facial telangiectasia you often see on patients, and the beaking of the nose. So you might even be able to kind of see a patient from the bedside and almost think that this could be systemic sclerosis. Raynaud's phenomenon is also seen in about 90 to 95% of patients, and females again tend to be affected more than males. Very importantly, it can be divided into two subsets, limited and diffuse. So the limited subtype, the skin tends to be affected the skin is affected only distally to the elbows and the knees, but it can also involve the face. And it's associated with features of Crest syndrome. And anti-centromere antibody is the antibody we tend to see here, associated with limited and Crest. And so Crest syndrome stands for calcinosis, in which you get deposits of calcium in the skin, and these can often ulcerate. Raynaud's phenomenon is a classic findings of the skin in the distal digits turning white, then to blue, then to red, then back to normal, and often occurring in cold weather. Then esophageal, E is for esophageal dysmotility, in which the patient can get difficulties with swallowing and can also often get bad reflux with this. And then S is for sclerodactyly, and sclerodactyly basically means local thickening and tightness of the fingers and toes, which can often give them a long and tapered appearance, and it can often also affect function quite considerably. And then T is just simply for the telangiectasia that we can often see, and it's called a mat telangiectasia. So that's the limited subtype, and now moving on to diffuse systemic sclerosis. So as well as affecting the areas distal to the elbows and knees, it can also affect areas proximal, so it can be quite widespread and can affect the trunk as well. And this subtype is more likely to have kidney, heart, and joint problems. Severe kidney involvement is rare enough, but you can go into a scleroderma renal crisis, and heart involvement can also be quite severe. The anti-SCL70 is unique to systemic sclerosis and is more likely to be associated with severe disease affecting the lungs. And this antibody is commoner in the diffuse subtype. And then ANA positivity is seen in the majority of patients with systemic sclerosis. So lung involvement is very important in systemic sclerosis, and it can present as pulmonary vascular disease evolving over time into pulmonary hypertension, and it can also present as an interstitial lung disease. Um, these two types are the commonest causes of mortality in patients with systemic sclerosis. Interestingly, interstitial lung disease is commoner in the diffuse subtype, and pulmonary hypertension tends to be seen more in the limited subtype. PFTs are very important to perform regularly to detect early interstitial lung disease, and you see a restrictive pattern, and one of the earliest signs is reduced transfer factor. Generally, treatments in advanced systemic sclerosis with visceral involvement are still not great. So I won't go into that here. So I'll now move on to lupus pernio, which is due to sarcoid disease, and you can get these diffuse kind of blue reddish plaques on the nose. If you look closer, we're not really picking up on it here, but you might see small red papules within the lesion. The other area you tend to get lupus pernio are on the earlobes. And then pre-tibial myxedema quickly is a rare complication of Graves' disease. Tends to occur when you have a high titer of TSH receptor antibodies, and you can get these raised indurated kind of pinky patches on the shins and on the dorsum of the feet, but they can occur anywhere.